speaker. There have been a lot of questions about treatment in borderline personality disorder in adolescents and young adults. And I think that even though Dr. Miller did not tell me to try and sell his book, it is really the Bible of adolescent treatment. Many of us use a lot of what he's written about. And without further ado, introduce Dr. Alec Miller.
So good morning again, everybody. There's been some feedback about whether you can hear the speaker through the microphone. How's the audio in the back? I'm also height challenged in some ways, too tall. So can you hear me in the back? Okay. So I have the ambitious task of trying to cover a variety of different topics in a brief amount of time. So I'm going to try to talk a little bit about the diagnosis issue, and then some about treatment, and then some about research, and then some about future directions. Now, anybody who knows me knows that I like to practice what I preach and think and act dialectically. And so here's the dilemma and the synthesis, as far as I'm concerned, when it comes to a diagnosis of BPD in adolescents. So on the one hand, despite the worry about stigma, despite the worry about whether treatment with BPD will be reimbursed by insurance, and despite the fact that many child and adolescent practitioners are not trained to assess or even, I think, necessarily believe in the presence of a personality disorder in adolescents, I think it is imperative to assess for BPD and even features of BPD so that we can properly assign the adolescent to the right treatment course. Okay? And in my biased opinion, of course, with adolescents, that would be DBT. Now, if we fail to do so, many of these teens who have BPD will instead receive alternative treatments, as you've heard this morning, and diagnoses such as ADHD, bipolar, depression, and then be placed on a variety of other treatment trajectories, usually including multiple medication courses and failed treatment trials. So that's one side of the dialectic. Now, on the other side of the dialectic, why be so concerned about diagnosis if DBT is effective at reducing problematic behaviors for teens with a whole host of diagnoses, including but not limited to BPD? It turns out, over the last 10 or 15 years, it looks like DBT is helping teens with bipolar disorder, those who have eating disorders, those who have substance abuse problems. So I will highlight for you in a few moments how DBT may be useful transdiagnostically. And we have a paper, book chapter that's coming out on that shortly. So maybe we should be focusing instead on reducing specific targeted behavioral problems, including suicidal behavior, drug use, disordered eating, blurting out in class, for example, regardless of the diagnosis, while simultaneously increasing new behavioral skills. So I'd like to propose that we honor the truth now on both sides with a both-and statement. And that is, it is both critically important to accurately diagnose a teen with BPD in order to assure the right treatment. And at the same time, it's critically important to now focus our attention on reducing specific problematic behaviors and providing replacement strategies and skills. So here's the middle path slide that really embodies what I'm talking about. You all know that the 9 white lines are the 9 criteria for BPD in the DSM-4, and those yellow subheadings, or headings rather, are the 5 problem areas of dysregulation that we talked about in DBT. Now, I know we can debate, Mary, for a long time what the central problem is, but at least from a DBT perspective, the central problem, as far as we're concerned, is emotional dysregulation, and as from that derives many trickle-down problems in interpersonally, and behaviorally, and so on. We've heard Ariel and others talk specifically about the cascading effects of relationships, problems, and behavioral problems. The sense of self gets, I think, confused. As I describe it, I feel like the water level for these clients is getting to this point where they can barely breathe, they can barely focus on anything else other than survival. So the idea that they can focus and be clear-minded about their long-term goals and their values is just an impossibility when you're in just survival mode. Let me get through this moment as it is. It is barely tolerable. So we take those 5 areas of dysregulation and put them in layman terms So the number three, emotional instability, is what we call emotional dysregulation. Impulsivity or behavioral dysregulation. Confusion about self is a sense of self-dysregulation, interpersonal problems, interpersonal dysregulation. And Jill Rathis and I years ago realized, working with teenagers, that we have these adolescent and family dilemmas that come up. And this is really another way of describing cognitive dysregulation. So cognitive dysregulation among BPD teens is where you're very black and white in your thinking. All good, all bad. I love, I hate. I'm terrible, I'm fantastic. So how to help teens find more of a synthesis in their thinking with themselves and their family members. So the question I have for providers today and consumers is why learn about and deliver or receive a new treatment for BPD? One reason might be that you don't know any treatment for this population and you're here to learn. Another reason might be that the old one doesn't work. Another reason might be that the new one has better outcomes. Or the new one has the same outcomes but is more efficient, is preferred by providers and consumers, and is more humane. So the Alec Miller bias opinion on why DBT. The data is so compelling. In other words, with adults, there are 10 randomized controlled trials that have been published demonstrating DBT to be more effective than comparison treatments. And that's including comparison treatments that are conducted by experts in other orientations. The data with adolescents is promising, and I'm about to show you that in a moment. But another reason why I think DBT is uniquely useful and effective and humane for adolescents is that there's a theory called the biosocial theory I'll describe to you in a moment that offers a compassionate explanation of the etiology and the maintenance of BPD, both for clients and their families as well as for professionals. And this theory, this biosocial theory, directly informs the treatment. As you'll see, there's the emotional dysregulation element of it, where we clearly need to teach emotion regulation skills. And then we have this, what we call invalidating environment, where we have to teach validation. Validation has to be learned by families, by teenagers, and by the individuals themselves so that they can validate themselves when feeling invalidated by the world around them at times. Another advantage of DBT for adolescents, in my opinion, it's skills-based. Teenagers are all about learning, practicing, rehearsing, getting coaching, and so I like this model because it's not saying that we can't rehabilitate them. We're saying they have skills deficits, and we're going to teach them skills to get more effective in all these areas, and we're going to coach them through it. And lastly, I like the multimodal nature of this treatment because we can access the teen and their families in very different modes and methods. So I'll talk to you about that as well. One of my pet peeves over the years, some of you may know, is when a community therapist approaches me and says, okay, Alec, here's the thing. I got a very challenging client, and I'm going to do the therapy, and you're going to do the DBT. Yeah. I'm going to do the DBT, and you're going to do the therapy. Let me just understand what that means. What they're trying to say is that I think the community doesn't always understand that DBT is a comprehensive treatment. It's not just the skills. And I think DBT sometimes gets a bad rap as a result of that. But if you actually understand this therapy, it is multimodal, comprehensive, and trying to address a multitude of aspects of the care beyond just teaching skills. So let me tell you how this treatment is for adolescents as far as we've developed it. So we think that as there's skills deficits, we have to teach skills. And who are we going to teach the skills to? Just the teenagers? No. We're going to teach skills to the teens and their guardians or caretakers or family members, so that everybody, as you've heard this morning, will have the same language, the same tools to work with each other. And in a few minutes, Jill Rathis is going to talk a lot about our multi-family skills training group. Then there's a weekly individual therapy where the teenager comes and talks to you about how to take those tools that they learn in the group and apply them specifically to their lives. But not just that, we want to understand in very specific detail, in a chain analysis, what are the key links in the chain that led to the problematic behavior? What are their thoughts, their feelings, their physiological sensations that may have preceded the dysfunctional behavior and then the consequences? So that we will then develop a solution analysis to come up with alternative ways to get down that chain and avert the problematic behavior. So there's micro-analyses going on here in detail to kind of get at the root controlling variables, and giving replacement strategies along the way. We also believe that if you're going to learn something, you have to get coaching. Whether you're going to learn how to do an out pattern on the football field, a slant, a button hook, whatever it may be, you need to get coaching on to make sure you know how to do it effectively. Brandon, I'm talking about your out pattern, you know that, right? So he doesn't need coaching anymore, let me be clear, but he had coaching at one point. We all need coaching, whether it be music, math problems, we need coaching, and life skills need coaching. So how can you just go to a class or go into the locker room and see the X's and O's on the dry erase board? That's not how you learn it. You see it, you hear it, and now you got to go practice and get coaching. So at DBT, we do have 24 hours, 7 days a week availability, as you heard from Ariel this morning, so they can get coaching. It's not just necessarily for suicidal and self-injurious behaviors. There may be a whole host of other problematic behaviors that need coaching. And we realized after a while working with teens and families that we want to give family members the availability of coaching too, right? They're coming to skills group, they're going to learn skills. The least we can do is provide coaching for them. So who are they going to call? They're going to call the skills trainers in the multifamily group to get coaching on how to deal with their teenager in that moment. We realized calling the primary therapist, if the teen's calling the primary therapist, the family member's calling the primary therapist, it gets a little ugly. So we make sure that we have a secondary person doing the coaching for the parents. We also discovered after many years of unfortunate outcomes is that if you don't involve the family effectively, you're going to have major family problems that will persist. Jen Steinberg's going to talk in a while about this, but really my feeling had been, bring the family in early, let's get down, let's roll up our sleeves, let's get down, let's solve these problems, okay, everyone's excited, yeah, let's do this. And in session 2, unfortunately, there was July 4th fireworks because the kids like, see, I told you this wasn't going to work, they're running down the hall, it's a complete mess. It occurred to me that people need to learn how to talk about the problems before they talk about the problems. So we need to teach validation skills at a minimum to learn how to listen to, acknowledge the other person's experience, even if it's different from our own, so that we can validate effectively. So that has to happen before you do any real problem solving with the family issue. And then the other modality of treatment that's just for therapy providers is a therapist consultation team meeting. And this is a meeting in which this is therapy for the therapists. There's such high rates of burnout in this field, I hate to say it. And without this therapist consultation team meeting, I would not be standing here today 20 years later. But it is because of my teams in different settings that help provide adequate support for me, help ensure fidelity to the treatment, and help make sure that I stay balanced with my clients. So if you don't have that built into your practice and you say you're doing DBT, I would argue you're not doing DBT until you have that in place. Now, if the adolescent and the family make it all the 4 to 6 months through that first phase of treatment, they're eligible for the second phase of treatment, which is the highlight of my week. It's called the DBT graduate group. Now, the graduate group, it was built to help maintain the teenager's gains, because without that, if you do any short-term treatment for multi-problem youth, you know what's going to happen, right? You're going to have major relapse in a lot of areas. How to sustain gains, you need some kind of modality to do that, and Sarah Steinberg is going to talk this afternoon in more depth about this, but it really, to see teens come in and get to the blackboard and start going on reviewing skills with their peers and having them consult with each other is the most rewarding thing I've ever seen. I can do this in the Bronx, I do this up here in White Plains. It is extremely gratifying to see these kids internalize these skills. And the best way to learn something is, of course, to teach it. So we're going to have them at the board doing that and problem solving with their peers. The goal ultimately is to fade out the individual therapy. We don't want to foster dependence long term. We want to get them the tools and get them to use their peers more for support and feedback, and then we can fade out the individual. So graduate group only might be ultimately a maintenance treatment. One of the core dialectics of DBT is woven into the DBT assumptions about clients and families and therapists. And I think it's very useful when you have a new family that comes into your practice to go over the DBT assumptions with them. So we often talk as the family comes in, I usually find the most disgruntled parent who's so burned out themselves, and I say, Mrs. Smith, can you please read number 1? And she says, people are doing the best they can. And then her eyes light up like, big silver dollars, and she's about to embark on a diatribe about how this is the most absurd statement she's ever seen. How could she be doing the best she can? It's out of control. Clearly not the best. Clearly not the best. So I say, Mrs. Smith, if Suzanne could figure out a way to be more effective and in control and not substance using and not self-injuring and not running out and not having impaired relations, don't you think she would opt for door number one and not resort to these problematic behaviors? If she could do better, don't you think she would? Well, I guess if you put it that way. This was not her dream adolescence to come here Wednesday nights from 7 to 9 and have multi-family group with you. This was not it. She had other things in mind when she thought about adolescence. So here she is. So I would argue, Mrs. Smith, that Suzanne's doing the best she can, and you as her parent, I think, are also doing the best you can. And I, as your friendly neighborhood skills trainer, am doing the best I can to try to teach this to you right now. Now, at the same time, I think she does need number three. Can you be number three? People need to do better, try harder, and be more motivated to change. Yes, that's true. That's absolutely true. I think that's true of her. I think that's true of you, and I think that's true of us as well. We're all doing the best we can. That's the acceptance side of the dialectic, and we all need to do better and try harder. Now, this theory, this biosocial theory I alluded to, I think actually treats the therapists who are working with these clients. It also helps enormously the families, the clients themselves. I would argue school personnel. I would argue medical doctors who have limited time to work with their patients. It changes the attitudes of the providers and the people around the individual, if you understand the biosocial theory. And I know I have a brief amount of time. I sometimes will spend an hour and a half teaching this, but I'm going to give you the 3-minute version. And that is, there's a transactional nature that happens for these teens. Right? There's clearly a neurobiological differences in their brains, where they are wired differently in 3 major ways. One, they're much more emotionally sensitive than their siblings or their peers. Things get under their skin easily. You know, it's kind of like a burn patient. If you go down to New York Hospital and you imagine sitting next to a patient with 3rd-degree burns in a room and the window's open but the door is closed. And you're sitting by them and the door opens. There's a draft of air that blows through that room and touches the burnt skin of that burn victim. They feel that exquisitely sensitively. You have no idea that breeze just blew through. So it is just this incredible emotional, high sensitivity. Then they also have high reactivity, incredible emotional poles of high anger, high shame, high sadness, high anxiety. And then you also have a slow return to emotional baseline. So when an adolescent with BPD gets emotionally dysregulated, it can take a long time to calm back down. Then you put that individual in what we call an invalidating environment, which I'll describe to you. An environment is comprised of multiple elements, I'll say, but it's the transaction over time between biology and environment. Environment affects biology, biology affects environment, it yields pervasive emotional dysregulation, and that is the crux and underlying point about BPD. So the environment I'm talking about, I want to be clear. Family members often feel blamed when they see mental health care professionals. Oh, is this like that schizophrenic parent thing you're talking about? No, this is not what we're talking about. We're talking about you may have 4 children, and for whatever reason, with this one child, you need to figure out maybe more effective ways of communicating with child number 3. And the other ones, it doesn't matter. But for this one, it does. You have to alter your methodology and how you communicate. And school staff, I can't even tell you. I'm at the school in the Bronx. I probably shouldn't identify the name of it, but there's teachers and administrators and security guards who I hear screaming at children and shaming them. And it makes me ill. But this is where kids are learning how to be young citizens. And that's the modeling that's happening. So there's pervasive invalidation at times in certain schools. We don't have to talk about the rate of bullying that happens and how that is a new risk factor for suicide in adolescence. So bullying of peers is so pervasive. Mental health professionals, I've heard and known of, and even myself on occasion has said or done something that's invalidating for their own client. And the healthcare system is now structured in such a way, and you all know, if you get 5 minutes with your medical doctor, you're lucky, right? And if in those 5 minutes they look up from the chart that they're typing in the computer, you're even luckier. And so when a teenager who's insulin dependent or has chronic kidney disease shows up and they're non-adherent, there's not a lot of time dude, you got to shake this up. You got to take your medicine or you're going to die. Okay, you get that? You clearly don't care if you want to live or die. You don't care. You don't care about your family. So there's a very narrow band of time that the doctors and nurses are trying to do their best thing, and it's very hard to get some validation in there. So we need to talk about that as well. Oh, I got 5 minutes. Okay. All right. So let me tell you a little bit about the characteristics of an invalidating environment. One is that the environment just rejects communication of private experiences. So, for example, a teen gets upset about failing a test. The parent says, it's your fault. If you study more, you would have passed. Or a seemingly benign version is, stop worrying. It's not a big deal, honey. It's only one test. Sounds so lovely, doesn't it? But if the individual is suffering and pain about it, that's missing the point. I get that you're really in a lot of pain about failing that test. I get it. Okay? Number two, sometimes the environment ignores or punishes lower level of emotional displays, and then when it escalates, then we attend to it and reinforce it. So the smackdown might be you're overreacting, it's not that big a deal, calm down. But then the crime escalates, and then the threat is I'm not going to go back to school. And now it's, okay, let's go out for a nice dinner tonight, you'll feel better, and I'll help you study more next time. So again, it doesn't sound so bad, we're going to make them feel better, go out for a nice dinner. But if you said that earlier, before the escalation and the threat came up, I'd be all for that. But no, if you're saving that after it escalates, then we're reinforcing extreme threat behavior. So you've got to be attending to when you address it at a lower level. In our busy lives, we have a lot going on, it's so much to attend to. But if you're more mindful, you will be able to try to attend to lower level communication and not reinforce the higher escalation. And last is this oversimplification, ease of problem solving and meeting goals. And just study more next time and you'll do great. Alrighty then. Yeah, just study more next time. This is, some of you know, this is the Nancy Reagan 25 years ago, First Lady said, I can't resist this, because she stands up at the podium in the 1980s and says, ladies and gentlemen, you have to sit down because I have the most incredible platform for substance abuse. Are you ready? Are you ready? Is everyone seated because you won't be able to even stand up for this? Just say no to drugs. Thank you very much. Now imagine being a 20-year heroin addict and the First Lady says, just say no to drugs and you will be fine. Like that. So when you find yourself saying, just do this, just do that, just do that, well, it might be easy for you to just say no to drugs or just study more next time. It's not necessarily so easy for them. So the just word is an indicator that you might be oversimplifying the use of problem solving. All right, so I'm going to move along a little bit here. I just want to say again that the teaching of this theory is so important. You don't want to rush over it for families. I think, again, it points to where do we intervene. Increasing emotion regulation, increasing validation. The problem, though, with many professionals about validation is they get anxious in the face of intense emotional dysregulation, and they want to kind of say, oh yeah, I can see you're feeling sad. So here's what we're going to do. We're going to get all these skills and strategies, but they skim over the emotional experience in such a way that that in and of itself, that skimming, I think can be invalidating. So I want to promote the notion of lingering on your validation. I hear how much pain you're in. This is really hard. Pause. Give them room for that to be digested and experienced and not rushed over. We'll get to skills, we'll get to change strategies in a moment, but let that be experienced. Otherwise, the anxiety by the therapist, by the family member is too palpable and it's not going to work. All right, so here's the data. I got my 3-minute drill. Are you ready? So, there's been multiple non-randomized trials, starting with Jill's and my study in 2002, and there's a little reference in your handouts to that effect. But there's several studies on adolescents with BPD, suicidality, and non-suicidal self-image. Then we have a whole set of research that's been done with other populations. This is this transdiagnostic notion I was talking about. Forensic youth, kids with ODD, oppositional defiant disorder, kids with bipolar disorder, Harriet Soundbach's done work with eating disorders, anorexia and bulimia. And of course, in long-term inpatient, mixed diagnoses, DBT has been shown to be promising for this population as well. Now, they're not randomized trials. You can only take so much from this. But I'm going to get to the randomized trials in just one second. I have to honor my friend. Where's Becky? Is Becky in the house? So there's Becky Hatcher. So Becky is one of my former students who's now attending in the Children's Hospital at Montefiore Medical Center. And she and Emily Israel and others realize that these kids are really non-adherent, non-compliant, and maybe there's elements of DBT we can use with these kids. So she found at Montefiore we have kids with chronic kidney disease who are blacklisted. They are so non-adherent with their treatment regimens, they're taken off the wait list for a kidney. So she took 6 of them and gave some real teaching on radical acceptance, on helping them learn skills about managing their emotions more effectively, and so on, for 6 or 8 sessions, and 6 out of 6 of them are now back on the transplant list. So there may be adaptations. Yeah, that's worthy of a hand. So there may be real value in trying to figure out taking certain elements of DBT that I think are universally applicable. Now, I can't help but honor my friends from Ardsley and Pleasantville, because DBT is now being used in some of our local school districts. Ardsley was the first one. They're the pioneers. Dawn Catucci right there. Raise your hand, Dawn. And her team from Ardsley. These guys have done an incredible job in the middle schools and high schools. There, Pleasantville, Mamaroneck, and Scarsdale are now starting. But the idea here is let's take these kids who are otherwise sent into other therapeutic schools and keep them in district and give them the life skills and tools right here at home. And we don't have to usher them out of district. So they've published it and presented at conferences. I'm very proud of you guys. Keep up the incredible work. But I really do think there's a movement afoot in which we maybe can take these life skills of DBT and put them into regular education classes. They're starting in a health class over there. Our friends Jim and Liz Mazza in the University of Washington are working with Jill Rathis and myself on writing a book for Guilford Press for DBT in schools where we can get these. I want to get these lessons in for 4th and 5th graders and get these kids learning stuff early on in life so we can maybe prevent and forestall some of the borderline symptomatology that might otherwise start and go into high school. But the pièce de résistance, s'il vous plaît. There are 4 randomized trials, 2 of which are done, 2 of which are now underway. Norway, New Zealand, University of Washington, University of Pittsburgh. The first 3 are all DBT with suicidal borderline spectrum teenagers. The 4th one is for suicidal teenagers who are also bipolar. So I just have to tell you, because my friend Lars Mellom in Norway, we went out there and trained up his team. They got to adherence. They've been coded to adherence. DBT versus treatment as usual in a 16-week trial, delivered in 5 clinics in Oslo, Norway. And the intermediate analyses, that means of the 80 subjects, we have data from the first 40. So it's not over till the fat lady sings, but I just want to say this. It seems feasible to implement in outpatient settings. This treatment seems to be well received by the adolescent parents with only a 15% dropout rate. And as you know, DBT, we're working with multi-problem youth in an outpatient setting. That's an incredibly good statistic. But what I really find impressive is there's significant reductions in self-harm and suicidal ideation in DBT as compared to the enhanced care as usual. And that happened early in the treatment period, and it's only a 16-week treatment period. So it's very promising data. We're going to look at the complete analysis of 80 subjects and conduct long-term follow-up, 2-year and 10-year follow-up. 10-year follow-up, this is almost like Mary's Xanarini range, 10-year follow-up. And then we're going to evaluate the graduate group as a maintenance therapy. I really want to see, anecdotally I think graduate group is fabulous, but I want to make sure that works empirically as well. Okay, so future directions. Published results from these trials. I want to see is DBT skills training with adolescents and families effective without concurrent DBT therapy? Is it effective for kids under the age of 13? Can we apply DBT in more restrictive settings, whether it be inpatient, residential, we know, therapeutic schools, or as well as less restrictive settings, and look at it empirically as well? And lastly, can we help prevent BPD and associated problems with DBT skills classes early in life? We have math, we have history, we have English. Can we have life skills in 4th and 5th grade? Please, can we do this? Anyone who's interested, we got to get on that. We are way behind. There's no reason why this isn't happening already. All right, so on that note, as Robert Blum said, youth is a time of opportunity, but also a time of risk. The risk for us is that if we fail to support the rapidly growing population of young people around the world, we'll be left to pick up the pieces. Thank you very much.